We know that coronary artery calcium is considered a measure of vascular aging associated with increased risk of cardiovascular and all-cause mortality. Well, in the March 2016 issue of JACC Cardiovascular Imaging, there is a paper trying to determine if coronary artery calcium is associated with incident non-cardiovascular disease. And to talk about this, I'm with Dr. Michael Blaha, who is an MD and Director of Clinical Research at Coronary Center for the Prevention of Heart Disease at Johns Hopkins. And the paper, the Association of Coronary Artery Calcium with Non-Cardiovascular Diseases, this is from MESA. First, remind us about MESA, because we have learned so much from MESA in the years.
Yeah, MESA is a fantastic study. It's an NHLBI-funded study. The goal was really to look at the implications of subclinical vascular disease, like coronary calcium. But of course, the main goal originally was to study cardiovascular disease, heart attacks and strokes. Moved into things like heart failure. But what we're studying here is something different, something people haven't studied as much as non-cardiovascular chronic diseases, like we'll talk about, but that includes cancer, that includes chronic obstructive pulmonary disease, chronic kidney disease. We also looked at dementia. So this is trying to move MESA into a new direction. In this case, we're looking at the association of subclinical vascular disease and non-cardiovascular disease outcomes.
Has this always been on the agenda, or is this something that just recently you thought, let's change this a little bit,
I think
let's change this up?
Because our thinking about subclinical vascular disease is evolving. We used to think of it as subclinical cardiovascular disease. But now we're thinking about it a little bit differently. We're thinking about it as the integration of risk factor exposure over a lifetime. So the measure of subclinical vascular disease, like the calcium score, integrates all one's measured and unmeasured risk factors for developing chronic disease. And the more we're recognizing that the determinants of chronic diseases across a bunch of organ systems are similar, the more this led to this project. So the idea that risk factors put you at risk for this with cardiovascular disease and cancer, cardiovascular disease and chronic kidney disease, led to this idea of, well, maybe this measure of subclinical vascular disease could predict age-related diseases in a variety of organ systems.
So what did you find? I mean, this paper is coming out in JACC Imaging. What did you find? Because I thought the paper was fascinating from top to bottom.
It is fascinating. Of course, coronary calcium predicts cardiovascular disease the best. But lo and behold, coronary calcium predicts other non-cardiovascular diseases that we just usually think of as age-related chronic diseases well too. For example, cancer. Someone who has a high calcium score has a higher rate of cancer adjusted for all the other usual risk factors. And someone who has a calcium score of 0 has actually a lower rate of cancer. It seems to be a healthy ager. Well, same thing for chronic obstructive pulmonary disease. Same thing for chronic kidney disease and dementia. Now, we know, especially when it comes to COPD, chronic kidney disease, CKD, or dementia, there's clearly shared risk factors, high blood pressure, high cholesterol, things like that. It's also interesting, it's been increasingly recognized that cancer has common risk factors too. People who have cardiovascular risk factors are at risk for cancer too. They have that vulnerability factor towards multiple diseases. So lo and behold, coronary calcium scores predict cardiovascular disease best, but other non-cardiovascular diseases beyond risk factors too. Interestingly, we can predict people at higher risk, but also the people at lower risk of those conditions. If you have a calcium score of 0, for example, something we call in a separate JACC imaging paper, the healthy ager, who has a persistent calcium score of 0 is the healthy ager, have a low risk of these chronic conditions, meaning they're kind of low users of the healthcare system. They're healthy agers.
So what's this tell us?
I think it tells us something biologically about what the calcium score means, about the underlying shared vulnerabilities to a variety of conditions. So clearly, first of all, at the biologic, pathophysiologic level, increasing understanding that risk factors lead to a variety of different conditions. They're not just cardiovascular risk factors, they're unhealthy risk factors for unhealthy aging. And that coronary calcium score is a measure of aging per se. It's not only a measure of arterial aging, but we like to say a measure of your one's biologic age. It teaches us that. Now, people have asked me, does it teach us about risk prediction, i.e. should I measure a calcium score to predict cancer risk? Yeah. I don't think that. I don't think we need to be measuring this for a reason to predict those other things. But it predicts cardiovascular disease, it predicts unhealthy situations that lead us to period. That we can tell to our patient that not only you're at risk for cardiovascular disease, you're at risk for a variety of things, and you need to get all your lifestyle risk factors under control to try to mitigate that risk. But it also tells us something from the health system level. It also tells us that we can identify patients that are going to be less users of the healthcare system and people that are more likely to be healthcare users, because we know that healthcare spending is concentrated in a subfraction of individuals. There's a subfraction of individuals that are people that are less likely to use healthcare resources. We think we can probably identify these people by looking at their subclinical disease burden.
Is there more reason now to get a CAC?
I think there's more reason every day to get a CAC score, right? Because we've learned that it predicts cardiovascular disease quite well, including both coronary heart disease and stroke. You know there's the new MESA risk score that was published in JACC recently, where we can go online and plug in your risk factors, plug in the calcium score, and get that 10-year risk that we've always wanted to have. We know from other JACC publications that the coronary calcium score best reclassifies risk after you conduct risk estimation with the new guidelines. But also now we know that coronary calcium predicts a bunch of other non-cardiovascular disease outcomes. So if you really want to understand where your patient stands in terms of risk, aging, et cetera, and can be able to communicate that risk to patient in a very clear fashion, I think the calcium score is the easiest way to do that.
It gives you a tool that you haven't had before.
The tool.
To try and hopefully persuade your patient, and also maybe to think of your patient at its more higher risk than maybe you had before.
And think about that patient in a slightly different way, and also communicate that to a patient in a different way. They commonly understand this idea that I've looked at your arteries in this case directly, you've got some early buildup, let me show that to you, and this is where you stand. So I think there's a lot of good reasons, and it is supported by the new guidelines, of course, with a 2B recommendation for those patients whose risk is uncertain.
Well, congratulations. Are you going to do more?
Of course we're going to do more. We want to look at the mechanism of this too. Maybe in a future JACC publication we can talk about why this is the case. We think underlying inflammation and things like that probably underpins a lot of these diseases. We'll come with that next.
Well, as you can probably tell, there's a rich library of material from Dr. Michael Blaha and company. So please go online. This particular one we're talking about is in JACC Imaging. It is the March 2016 issue. For Cardiol Source World News, I'm Executive Editor Rick McGuire.